Hi, everyone. Happy Wednesday.
Welcome. Thank you for joining. We're here in Houston as always. It's warm weather. We are expecting a baby anytime.
Wouldn't that be a memorable VMR?
Yes, it would.
Just kidding.
So before we forget to mention later, we're going to miss the next 2 Wednesdays. Hopefully someone else from the CPS team will be able to fill in, and there will still be a VMR, but it won't be us. And then slowly, maybe a couple of weeks from now, we'll start coming back. Maybe just me, maybe both of us, maybe all 4 of us.
We'll see. We'll see how good of a clinical problem solver he is off the bat.
Yeah. I think the differential will include a lot of
yeah.
So we'll ask for some friendly volunteers to share a case with us and discuss the case with us as always. In the meantime, I actually missed Monday's VMR. It seemed like I looked at the PDF and it seemed like a really cool case, and always with great discussants and Jack Penner in this case involved. So I look forward to hopefully catching up later. But by way of just warming up and getting us thinking about some stuff, I wanted to share some thoughts about the process of taking a history. I was filling out a student's evaluation the other day, and I realized that I almost never give top marks for the history taking skill assessment, because the anchor on the top mark says always elicits a perfect basically it says is perfect at taking a history, always elicits a precise, accurate, complete history with subtle information and nothing at all lost. And I think it's actually kind of a disservice, both for more literal graders, I guess, like me, but also just to set that expectation. I think in general, we tend to talk about, taking a history as this core medical student skill. And I really feel like it's much more of a complex, nuanced, and sort of a lifelong skill, right? A medical student's evaluation would never say consistently and always is perfect at making complicated treatment decisions, because that's just not possible.
My evaluation wouldn't say that.
Well, I would not at all give myself top marks for that history scale either. And I know, Steph, you feel the same too. So I really do think that there's the being able to kind of go through the basic mechanics of having a conversation with the patient and trying to elicit a history, right? But I feel like depending on the patient, depending on the case, depending on your sort of communication mindset of the day, there's so much that can go wrong, and there's so many layers of kind of skill level to more effectively, more accurately, more efficiently be able to get to the bottom of the truth of what the patient was actually experiencing and how that might translate to a pathologic process. So I actually want to invite everybody on the call to just take a minute to think back to the last few patients you've seen, last few times you've had to kind of talk to a patient from scratch and try to understand their symptoms. And think about something that was hard, something that tripped you up, something that was misunderstood, something that came out later, something you missed, and maybe pair that with a lesson you can think of about how maybe next time with that experience you're going to be a little bit more skilled basically at avoiding that same challenge again. And I'm really hopeful that a couple of people can unmute and share or type in the chat, just again, while taking a history, what was hard and what could be a tip or a trick to try to work around that difficulty.
I guess I'll start. So So, hi everyone, it's Drew. I had presented the case yesterday or Monday, and I think the big thing for that case in particular, and just in general, is just being able to communicate with the patient in a way that you can get information, the necessary information, and also be able to make sure that they are as comfortable as possible in a difficult environment. Just to give you a little bit of a teaser for yesterday, the case involved an autistic young adult who was, in an unfamiliar environment. He was COVID positive, and all of that sort of complicated being able to get a history from him, because he, was, I guess, permanently shut down and was not able to verbalize as would be expected of someone who is neurotypical. Valeria has a case. But to wrap up briefly, it's so hard. It's honestly hard to be able to get rid of the bias that, oh, this patient by chart is nonverbal, I'll have to go some other route. Always, 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 no matter what, just try speaking to the patient and try finding some way to be able to communicate with them, because you are going to reaffirm their humanity and you will make them far more comfortable.
Thank you, Drew. That was really beautifully said, and I completely agree with your message. Can we get a couple more?
Scott commented in the chat, just asking a tough question that the patient had difficulty just talking about, like felt ashamed, but that actually like getting out there that it was a difficult subject to actually talk about was an important obstacle to overcome. I've totally know what you mean, Scott. Sometimes that's why one of many reasons history taking is iterative, right? The patient will get more comfortable with you the more they see you, and some of those tough topics get a lot easier.
And were you saying, I had a case of a patient with blurred vision and severe headaches. I spent a long time trying to figure out the cause, ended up getting an MRI because the cause was unclear. It showed subacute subdural. I had asked him about falls and trauma, but later it came out that he had been assaulted a few weeks earlier. I did not obtain history in such a way that the patient felt comfortable sharing this with me. Wow, Anne-Marie, thank you for sharing. Yeah, sometimes that gets, like, it almost becomes a joke, right? Like, I think Dr. Glockenflecken on Twitter had posted that like video about, the student asking about allergies and asking like a million different ways. Any allergies? Have you ever, and the patient's like, nope, 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 nope. And then the attending comes in, is like, any allergies? And like, oh yeah, I'm allergic to sulfa, penicillin. And it was like, it was obviously a very funny and popular video because it speaks to so many people, right? Like, it feels true. And I think all of us have had that experience where, the next person comes in a room, asks the same question, right? And you're just like, what? Like, I asked you and you said the opposite answer. And I really believe that it's not that the patient was like trying to, deceive you, but rather that like the specific circumstances, the specific wording with which the question is asked, the comfort level potentially that patient develops over time or with a different person, like it's those differences that lead to so many quote unquote like different versions, right? But there's only one truth. Anyway, and sometimes that truth is actually elusive to the patient themselves. It's hard to remember everything, like anytime, but especially like at 4 a.m. when we're sometimes taking our histories and stuff, right?
Yeah, I appreciate that. I just think history taking is something that I've actually just tried to get better at recently, right? You learn it as one of the first things in med school, but it's actually one of the hardest skills. And in these case conferences, we put together this beautiful history that's nicely done for the exercise, but it's quite a journey getting there. So I appreciate that.
Scott is commenting on just rumination and how over time they realize again that the truth might be like the answer is actually different than they initially thought.
Yeah.
Thank you everyone for engaging with that. I think I just think it's an interesting topic, and we spend so much time here interpreting information, right? But I think you have to gather the information first in order to interpret it, and if it's not the right information, then you're interpreting wrong data and going. So obviously everybody on this call is spending a lot of time trying to work on their skills of in data interpretation and application and synthesis and analysis. But I just want to throw that out as sort of a parallel goal to try to work on data gathering skills, whether that is, the history, chart review, which is like a whole other skill, I think, that I'm not as good as a lot of my colleagues, I think, and then physical diagnosis as well. All right, where's our case?
We're good to go. We have a case and two discussants. So Kirtan, maybe if you want to go first, say hello, then Anusha can, and then we'll have Valeria say hi before she begins her case.
Yeah, so hey everyone, congratulations to you first. And I came here previous week too. So looking forward to today. Let's figure out the case today.
Great to see you again.
Yeah.
Hi everyone, this is Anusha Chidarla. I'm PGY3 Internal Medicine resident. I'm going to pursue my Hem-Onc fellowship at Kansas University next year. So I'm excited to start the case and discuss with you guys.
Congratulations on your next step in your career, Anusha.
Thank you.
All right, and Valeria, say hi and kick us off.
Hello everyone, I'm Valeria. I have presented a couple of times before. And I just wanted to say before starting that today is Trans Day of Visibility. So it's another population that we have to take in consideration when doing a good history and physical exam. And yeah, I mean, they're rightly so still a barrier to communicate with trans people. So we surely need to work on that, especially here in Peru, where it is not very common to see in our curriculum health education or trans health education. So yeah, with that, I think we can kick off the case. So it is the chief complaint is elevated transaminases. I don't know if you want to discuss this first, or should I give you a little bit of the history?
Let's start there. Kirtan, if you and I want to team up, what do you just think hearing that we know right off the bat there's abnormal liver biochemistry labs?
Yeah, so there is a lot to think about. I mean, we just have few information as of now. Now talking about the time course, talking about the possible etiologies, we can think about infectious causes. Like let's say it is a hepatitis group of viruses is causing that. And if it is indeed hepatitis, then what kind of hepatitis? Whether it's A, B, C, D, E, and time course and the risk factors can guide us into which direction we should move forward. Apart from hepatitis group of viruses, certain infections like herpes group of viruses, let's say HSV1, HSV2, EPV, VZV, CMV, all of them can cause liver inflammation and can elevate the liver enzymes. So that's the way to think about infection. Then we can think about what if there is an abscess in the liver. Even abscess can sometimes cause elevated transaminases levels. So that's about the infection. Now what about the metabolic causes? I mean, we can have Wilson's disease, we can have alpha-1 antitrypsin deficiencies, we can have all sort of disease disorders which can present in this manner. Then what about toxic etiologies? So we can have lots and lots of drugs, like literally thousands of drugs can injure the liver. Then what about alcohol? So all those things we have to take into consideration, and it will be interesting to see whether AST has risen, whether ALT has risen, or whether alkaline phosphatase has rise. I mean, all of them have rise proportionately or disproportionately. That can guide us regarding whether we are dealing with cholestatic problem or whether we are dealing with hepatitic problem, right? Whether it's a mixed pattern of injury or predominantly transaminitis kind of injury. So that can give us clue about whether there is some obstruction in the bile ducts. So gallstones are there, pancreatitis is there, all the mass lesions which can cause that, all sort of tumors can cause that. So what is the cause? And lastly, infiltrative liver disorders. Sometimes infiltrative liver disorders can also raise the alkaline phosphatase, can also raise the ALT, AST. Autoimmune diseases, as always, can cause that. But right now, we will look for more information and then we can zoom in on what can cause this.
Beautiful, Kirtan. Just off the bat, having so many possibilities that could be going on with the patient. Beautiful to hear you talk through that. Before I highlight something really fantastic you did, I will just zoom out and share two things to keep in mind when the chief concern is an abnormal lab. The first thing to keep in mind is what do we know the chronicity of it? Is this something that we know for sure is acutely a new problem? Is it something that has been going on for a while that we're now starting to investigate? Or do we not know and not have data points in the past to guide us, in which case we may be suddenly finding an old problem or identifying a new problem de novo. So I think the time course.
Quote? You have a good quote for that. The acute discovery of
the acute discovery. Oh, I can't remember what it is in pithy way.
The acute discovery of a chronic problem does not make it an acute problem.
Yeah.
Is that right?
And I think that's very true with labs when someone may not have had labs checked or they had labs checked in a different health system and we don't have access. So working on the chronicity, no matter if we're talking about liver biochemistries or kidney numbers or a white blood cell count that's low, is an important part of the diagnostic process. The second piece I'll add in general for abnormal labs is the patient symptomatic with this or not? And we'll hear as the history unfolds if we have symptoms that are concerning for a primary hepatobiliary process that kind of Kirtan started discussing through. So just those are the two things I think are most important when someone is referred for you for abnormal labs: time course, if known, and symptoms or not. And then finally, Kirtan, what I loved about your discussion is before really digging into the workup of what it could be, trying to characterize the pattern of the lab abnormality is very important. And I'll just highlight the wonderful framework you gave us already for abnormal liver biochemical tests. 4 main patterns to look for: predominant hepatocellular, where the AST and ALT are the most abnormal, with the parentheses that we have to be careful and look for non-liver causes of those to be abnormal, like muscle or red blood cell breakdown. You mentioned a cholestatic pattern where the bilirubins and alk phos are most elevated. You mentioned a mixed pattern where it's really a blend of AST, ALT, and bili and alk phos. And then finally, off the bat, you mentioned the infiltrative category as well, where primary alk phos elevation is going to be the pattern that we identify. So let's just stop there. There's going to be a lot more, but I got excited, and that Zavan nudged me and said, "You go first," because I think it's a very internist pleasure to talk about abnormal labs as the main issue. Back over to you, Valeria.
Great discussion, guys. So actually the patient physician detected these elevated transaminases in her annual check, but she referred, well, it was a 45-year-old female that referred a history of 5 years of petechia in her lower extremity associated with greasy food. And these lesions kind of went away 2 or 3 days after they appeared without any treatment. And she also referred that when these episodes occurred, she felt really tired. And she also referred some articular pain and myalgias. And there were no symptoms between episodes. I'm sorry, it was 2 or 3 months history. The 5 years is another past medical history. Yes. So, and in her past medical history, it wasn't really anything relevant, nor any social history or family history, and she didn't take any medication.
Valeria,
So I think this will be a good.
yeah,
Yes.
we'll Anusha and I will try to see what we make of this in a second. But can we ask a couple of follow-up questions? Anusha, did you
Yes.
have anything you wanted to ask?
So any diarrhea?
No. No gastrointestinal symptoms beyond the petechiae with greasy food. That kind of.
And then did she describe the petechiae more, or could you describe them just so that we know what we're dealing with?
Yes. Well, so when she presented to the hospital, she wasn't on an episode, so we couldn't see them, but she referred them as kind of erythematous lesions, small lesions, multiple in both of her lower extremities, in her calves, and that they didn't disappear when she pressured them. So that's why we
Did not disappear.
Yes.
Okay, and they were like bright red, not just like pink or, you know.
No, they were bright red, red or purple.
Okay. Any associated abdominal pain?
No.
Any blood in the urine?
No. No, no other symptoms.
Any family history of autoimmune diseases? I know you said no family history.
No, the patient didn't refer any family history.
Okay, great.
And one more, Valeria, sorry. The greasy foods, could she elaborate more like what the greasy foods that she eats tend to be?
Yeah, she referred when she ate like fried chicken mostly, and it was something that she ate like 2 or 3 times a month. So it was when she ate that type of food that she had these episodes.
Okay, thank you.
Okay. So shall I go ahead?
Please.
Okay. So it seems like a subacute to chronic course, like 2 to 3 month history of petechiae. Petechiae, whenever I hear the word petechiae, then I think about like, is it a problem with the platelets, or is it a nutritional problem like vitamin C deficiency or something like that? Or is it a problem with the vascular, like any vascular abnormalities or anything like that? So in this case, with elevated transaminases and stuff, now I'm leaning towards like, is there a liver problem which is causing her to have a petechiae? So in patients with liver problems, we know that the INR will be low, and also they are more prone to have thrombocytopenia. So is that the cause for petechiae in this patient? And so the thing is, she has multiple red, purple lesions, which did not disappear on pressure. That means it's non-blanchable. Whenever I see something like that, it's non-blanchable, then I think of some autoimmune diseases or some skin rashes, which are non-blanchable. And maybe she has some autoimmune disease, like she's a female and she's in the range like young adult range. So she might have an autoimmune disease, especially with her other symptoms like tiredness, pain, and myalgias, which most likely are seen in some autoimmune diseases. I'm leaning more towards an autoimmune disease in this patient. But the interesting thing here is this is all associated with the greasy foods. So whenever I see that it's associated with greasy foods, then then it makes me think, is it a cholestatic thing? Because in cholestatic in cholestatic pattern of liver enzyme elevation, basically what happens is when patients eat fatty foods, then your gallbladder tends to contract more. And then you have a right upper quadrant pain. That's the reason I asked, is there an abdominal pain? But this seems to be interesting. There is no abdominal pain, but I'm leaning towards some kind of an intestinal problem. Maybe she has malabsorption with the greasy foods, or maybe her symptoms are getting worse with the greasy food. I'm not entirely sure how to take that though. So for now, my differential diagnosis are, I know that it's a liver problem. Maybe the petechiae is from thrombocytopenia or elevated INR kind of stuff from the liver problem itself, or an intestinal malabsorption problem like vitamin C and scurvy, or it may be any infectious process or a Hemolytic process too. And with the greasy food, it's getting elevated. The symptoms are getting aggravated. That means, is there a cholestatic pattern of picture of liver enzyme elevation? I'm not entirely sure what to take with the greasy foods. And is there a pancreatic problem with the greasy foods? That means if there is no lipase production, then that might be one of the reasons for her symptoms getting worse with the greasy foods too. And the tiredness, pain, and myalgias in a young adult female with all these other symptoms, it makes me think more about like an autoimmune process, likely. Yeah, that is it. It's very interesting.
And Anusha, thank you. And I was like very relieved that, you know, I would get to hear your thoughts before I would have to share my own, just because that's always a little bit easier. In fact, have I ever said this, Steph? The idea that like we should sometimes like flip the order. Like we should go first and then have y'all react to us and build on what we say, because we always have it easy, I feel like, because you guys lay out all the, you know, all the groundwork and like generate all the ideas, and then we just get to, you know, add some commentary or like highlight the salient points and stuff. Anyway, yeah, I'm similarly confused by the Greasy Foods Association, and maybe I'll start there. Like, I think the first maybe kind of self-defensive mechanism of not knowing what to make of that was to think of the, you know, the valid point that a lot of times we associate certain things with each other, and it's actually, you know, not a real association, right? We want to see patterns, we want to make connections, but sometimes it's just correlation. Like it's very common, right? Anytime we develop any kind of gastrointestinal symptoms, to think about the last thing we ate. Oh, it must have been the tacos or the burger or whatever. Well, I eat tacos and burger every day, like, but I didn't get diarrhea the last, you know, 2 months, right? Now, in this case, it's less intuitive to connect this like leg rash to what you eat, right? But a lot of people do just associate and put a lot of stock into the food that they eat affecting a lot of things about their body. So there may still be sort of an attempted association that the patient may be trying to helpfully note that, again, may just be coincidence, right? So I think that's a possibility. And for that reason, we shouldn't overlook pathologic processes that to our knowledge, don't have anything to do with ingested food. Now, that being said, there's a lot we don't know. And it's entirely possible that many immune-mediated processes, for example, are influenced by kind of the daily antigenic exposure that, or kind of pro versus anti-inflammatory balance of things that you ingest or your body is exposed to. So that may just be something outside the understanding of medical science yet, but it may entirely be, for all we know, that, you know, that leukocytoclastic vasculitis is exacerbated by like exposure to certain foods. Like we just don't know that yet, right? Who knows? The other thing the reason I was asking Valeria about the details of like what she's eating is, you know, fatty foods as a category. Okay, fine. Like what processes can arise when you have like, you know, a lot of fat in your, you know, introduced into your stomach, into your duodenum. And Anusha, you touched on that, right? Like the pancreas gets worked up and starts juicing, the gallbladder gets cholecystokinin and starts squeezing. So you can think about those consequences. What else happens in the bloodstream? Your triglycerides go up, right? So what could that cause? Some kind of, you know, I don't know, changes in viscosity or changes in circulation, changes in whatever, like pancreatic injury, other things. But I'm coming up short in terms of how to actually connect that to her actual symptoms, right? So it could be the grease, right? Or could it be the actual greasy type of food that she's eating? You know, does she have some kind of an allergy to a particular actual substance, a particular protein, whether that's, you know, the chicken or beef or whatever else it might be, or spice, I don't know. But again, this isn't like a very typical presentation of a food intolerance either, right? No GI symptoms, no pain, no nausea, but instead, you know, there's PTK, and then the systemic, it seems, symptoms of fatigue and myalgias, which at this point I'm having trouble making too much of. It just seems very non-specific, not necessarily discriminating between any of the processes. But you're absolutely right. It could very much be just part of like an immune-mediated process, right? Okay, so I think the most objective thing we have to kind of anchor onto is the petechiae, which it really does sound by description to be kind of like vasculitic, right? Like skin vasculitis. And to expand on that a little bit, the way I think about basically this kind of, you know, bleeding in the skin is it could be low platelets, as you said. It could be bad platelets, and those are usually pretty easy, right? Like they show up on the CBC, or you have a history of being on dual antiplatelet therapy or whatever. And then the last category you mentioned was like capillary, like actual integrity of the blood, the small blood vessels in the skin. And if you're not vitamin C deficient, which we should maybe get more nutritional history and make sure that she's not like totally, you know, not eating any fruits and vegetables. But if you're not, then it's basically vasculitis, right? It's small vessel vasculitis. And the pathologic kind of term for that is leukocytoclastic vasculitis. That's the label that you get when you biopsy, you know, vasculitic petechiae in the shins or calves or whatever. But that is not a final diagnosis. That can be an isolated process of leukocytoclastic vasculitis just in the skin, and it's usually pretty benign. It can be treated even with like topical steroids and respond, but it may be part of a broader small vessel vasculitic process in the whole body. The categories of which include, you know, ANCA-associated vasculitides, IgA-mediated vasculitis, Henlock-Schönlein, purpura, etc. Cryoglobulonemic vasculitis, which maybe could overlap with chronic asymptomatic hepatitis C, in this case, accounting for the liver function abnormalities. Anti-GBM disease, and a few other sort of isolated diseases and categories. But I think what we have now basically leaves us kind of confused and at a loss. I think we should do I guess we've already done a thorough review of systems, and we haven't found other signs of pulmonary involvement, renal involvement with urinary changes and, you know, foaminess and redness and things like that. Nor any kind of systemic rheumatologic symptoms with the eyes, with the mouth, ulcers, other rashes anywhere else, any joint pains. So we're a little bit stuck, and I think we should do a thorough exam to kind of correlate and find findings maybe that we didn't get on history, as well as obviously the details of the lab workup that we've already mentioned is going to be really critical.
All right, we're ready.
Okay, guys. Yes. So actually, the patient didn't refer any allergies, and the physical exam shows a febrile with 36.5 degrees, a heart rate of 90 beats per minute, blood pressure 100 over I have 100 over 75, and respiratory rate 18, and she was saturating 99% on room air. On general examination, the patient actually didn't show any, she seemed healthy. She didn't have any lymphadenopathy, any neck or cervical masses. On the cardiovascular exam, there were no murmurs. Both S1 and S2 were present, and on pulmonary exam as well, it was normal. On abdominal exam, and skin exam, we didn't see any jaundice, any hepatosplenomegaly, no ascites, no cirrhotic kind of signs like caput medusae, or the patient also didn't refer any history of hemorrhoids. The neuro exam also was normal. The patient was oriented on time, space, and person. It was not pruritus on history. The skin was hydrated. The patient wasn't pale. And there were no petechia in exam on presentation. So it was actually very unremarkable. But we did do some exams when she was admitted. And her hemoglobin was 11.8. Her glucose was 100. Her creatinine was 0.7. Bilirubin, I don't have the exact values, but bilirubin and alk-phos were within normal limits. And sorry, because of her blood count, it was also normal. Leukocytes were 8,750, and platelets were 350,000, and the differential for the leukocytes were normal. But the transaminase when admitted were 111 for the AST and 162 for the ALT. Her total proteins were 10. Albumin was 425 and globulins 5.82. So you want me to stop here, or I can give you some imaging to start?
Let's stop there.
Okay.
Kirtan, would love to hear your thoughts on the exam and then the labs.
Yeah, so basically we are at the same level where we were a few minutes ago. I mean, there is nothing that pops out in the examination. The BP was a little bit low, but I mean, the patient was not symptomatic enough. The BP is 100 over 75, but the patient doesn't complain about it. The patient seems healthy. There was no jaundice. And I was really looking forward to see how the calcium and phosphate levels were, because layering on what you discussed, that if it is indeed a malabsorption problem, and we are dealing with all the malabsorption of vitamins like fat soluble vitamins, let's say vitamin A, vitamin D, vitamin E, vitamin K, and if the calcium and phosphate are low, then they can even explain the tiredness, pain, myalgia, all the non-specific symptoms. But as of now, we don't have any evidence of that because the patient didn't look pale. So I mean, the anemia is out of the bag, and all other nutrients which can cause tiredness, they are also out of the bag because the patient seems healthy. And as of AST, ALT now, we are sure that this is a hepatocellular pattern and this is not the cholestatic pattern. But now what to make of it? I mean, AST, ALT are not sky high. They're just like 2 to 3 times upper limit of the normal. So now I was thinking about if it is a celiac disease, if it is malabsorption. Celiac disease can even cause fatty acid malabsorption, and celiac disease can present in this way. It can cause non-alcoholic fatty liver type of pattern, and that can cause rise in AST and ALT levels. And the patient has symptoms with greasy food. So I mean, we don't know how much amount of fat the liver has accumulated over the years. I mean, there was no evidence of cirrhosis, but we know that non-alcoholic fatty liver often presents in a benign way. We need ultrasound to look for the fatty deposition there. So I'm not sure, I mean, what to make of AST and ALT as of now. And then, of course, there are weirder causes of malabsorption like Whipple's disease. Now, Whipple's disease can present as hepatitis, but I have not seen conclusive evidence that it can cause AST, ALT like this. So I'm still at a loss what to make of it. The globulins are a little bit low. So now one rare possibility is that lymphangiectasia. Sometimes what happens is that intestinal lymphatics get dilated and they start to lose the proteins. But it will generally cause more severe malabsorption, not just 5.82 of globulin. It would cause globulin of like 2 or 3. So even lymphangiectasia, I'm not sure what to make of that. And then as Javan mentioned, that is it a leukocytoplastic vasculitis? Now, if it is indeed a case, then it would be interesting to see how the ESR and CRP levels were. As of now, creatinine was fine, so no inflammation in the renal. So what to make of it, I'm not sure. Can you help me, Steph?
I'll try. What a wonderful foundation you've set though, Kirtan. I agree. The exam, right, doesn't add too much to what we're thinking. I will just say in general, someone with intermittent and then resolving skin changes or anything going on in their body in this day and age with everybody having a mobile phone, asking if they have photos of when it happened is just an extra thing that we should include in part of our exam for intermittent disorders. But otherwise, I agree. We really need to start working on the labs fitting into the story. And I completely concur. We can really now settle on our diagnostic schema for hepatocellular injury with a slight ALT predominance over AST. We can feel pretty comfortable at this point saying this probably is a hepatic process. The AST being greater than the ALT would be our flag to really make sure there wasn't chronic muscle breakdown, making sure there wasn't red blood cell breakdown. We don't have that signal here, nor do we have a high concern for that. Although we do need to make sure we also think about her anemia separately. I love some of your initial thoughts about what could cause this pattern in her, from celiac disorder, otherwise non-alcoholic fatty liver disease being important. And then we don't really have a clinical history of an acute viral hepatitis syndrome, but that wonderful differential of viral hepatitides is something we'll have to think about, particularly those that can lead to chronic disease, right? Hepatitis B, hepatitis C. Particularly because of the overlap those can have with vasculitis, which Anusha and Zavin already yielded to, with hepatitis C and cryoglobulinemia, hepatitis B and polyarteritis nodosa. So I think standard hepatitis serologies will be important. And then particularly with the globulin elevation or the protein gap that she has, I do think at this point, making sure we consider autoimmune hepatitis causes is important also. She has elevated total protein with a normal albumin, suggesting there are proteins around in excess that aren't usually there. And the definition of the protein gap or globulin elevation is one, the difference between the albumin and the total protein is over 4. So that's something we need to explore a bit more in the context of this episodic petechial myalgia syndrome, as well as the hepatocellular injury. And keep in mind that these extra proteins can be many different proteins, meaning polyclonal, which can happen with autoimmune conditions like autoimmune hepatitis, happens in HIV, happens in chronic hepatitis C. And then, of course, they can all be the same protein, meaning a monoclonal process, which we will look at with plasma cell disorders. So as we're sort of building this problem list, I've mentioned sort of the episodic petechial kind of fatigue myalgia syndrome, the hepatocellular injury, and we've got this globulin gap as well to start working up. And I think, Kirtan, you've set us off on a great standpoint to think about viral hepatitis, autoimmune hepatitis, celiac is very important. The final thing is to kind of Zavin's initial reflection on the importance of history. We should go back and take a little more history regarding the anemia in particular. A woman who's 45, most important is assessing for menstrual blood loss as a cause of anemia. But you mentioned malabsorption already, the whole group has. And so the menstrual history becomes important if we find iron deficiency, really getting a sense of, is it from, typical blood losses with her cycle, or if her cycles are really not heavy, do we have one more parameter that could fit for the question of malabsorption, given this association potentially with food at times?
Or GI involvement with blood loss in the intestine.
Or blood loss from somewhere other than the GU tract, yeah. Let's stop there and get some more from Valeria and see how we can build on that. Great job, Kirtan.
Yes, guys, so we were actually thinking about the same things. Actually, this is a patient that I saw just last week. So we did a coagulation panel. Her TP was 12 seconds and her TTP was 37 seconds. We also did a rheumatoid factor because one of the things that we were thinking as well were cryoglobulinemias, and it was negative. Also, urinalysis, that also wasn't remarkable. No kind of IgGs to make us think of something more like autoimmune, but also not necessarily takes it out of the differential. We also did a PCR and ELISA of hepatitis C and hepatitis B, and they were both negative. And we also did an ANCA that was negative. Also, and I have, I think, okay, I haven't given you the ultrasound, the abdominal ultrasound. So it showed some, I don't have the complete description, but the physician kind of described it as having signs compatible with a non-alcoholic fatty liver. And yeah, I have one more test that kind of will give us a final diagnosis. And I don't know if you can discuss this information.
Sure, Valeria. Did you mention an ANA?
No, ANCA, and ANCA.
Okay, all right, thanks. Okay, what do you think, Anusha?
So coagulation panel, the PT and PTT are normal. So it doesn't seem to be like a coagulation factors abnormality like we see in liver disease. So AST, ALT are high. So my first thing would be like viral hepatitis panel, which is negative though. And the globulins are high. So we definitely have cryoglobulinemia on her differential. And in the cryoglobulinemia, it doesn't have to be an acute viral hepatitis. It can be a chronic one too. So we need more labs, whether it's a chronic one like a hepatitis B, other antibodies like IgG antibodies and hep C IgG antibodies, and those all things as well, to see if the patient has a chronic infection going on. And rheumatoid factor is negative and ANCA is negative. It would have been great if we have a ANA panel. There can be ANCA negative vasculitis as well, so that doesn't help us much. So, but it will rule out like the leukoclastic. It won't rule out, but like it will be like a helpful to rule out like a leukoclastic vasculitis and stuff though. And the abdominal ultrasound, it showed signs of non-alcoholic fatty liver disease. That's one of the most common one we see on the abdominal ultrasound. I would like to know her BMI as well. Like, is she obese? And also I would like to know her lipid panel as well to see if she has any increased triglycerides and any other lipids which are increased, basically, like cholesterol levels and those. And right now we have it. We know that it's a hepatocellular pattern, and we know that the globulins are increased. So we can also get some labs like the cryoglobulin levels and stuff. But at the same time, if she had a rash, that would have been good, because we can just take a biopsy from it and see if we can find anything like cryoglobulinemia or something, some kind of a vasculitis like picture. If she has a rash, just taking a biopsy would be helpful. But right now I'm leaning more towards a previous hepatitis B infection or the hep C infection causing her to be in cryoglobulinemia with this AST and ALT elevation. And for the hemoglobin being low, 11.8, going into hemonc, I would like to know a peripheral, I would like to have a peripheral blood smear, and also MCV, MCHC, and those all indices as well, to see what kind of anemia that she have. And if the MCV is low, we know that it's iron deficiency anemia. Is the iron deficiency anemia from malabsorption? Is the iron deficiency anemia from GI losses? like, is she having any chronic blood loss that's causing her to have iron deficiency anemia? So I would like to have a peripheral blood smear there, and I would like to have a ANA panel, and also cryoglobulin levels in previous, like hepatitis B, IgG, and Hep C IgG levels as well. And her BMI to see if she has any obesity, and also lipid levels to see if she has any elevated lipid. And also a biopsy would be helpful.
Anusha, that was awesome. I think if Valeria can correct me if I misunderstood, but maybe it sounds like the patient did have an ELISA, like an IgG antibodies and viral load for hepatitis B and C, and those were negative. But I agree with you that cryos remain on a differential, because only about half of cryoglobulinemia is driven by hepatitis C, and you can just have other types of mixed or other cryos that are sort of independently mediated. And then, Valeria mentioned this as if it was, commonly known, but I think it's actually a really good teaching point in there why the rheumatoid factor was obtained. Not only is rheumatoid arthritis and rheumatoid vasculitis potentially in a differential, but I think about 80% of cryoglobulinemia will have a positive rheumatoid factor assay. So it's kind of like a poor man's cryoglobulins, and oftentimes it can decrease your degree of suspicion, because actually performing cryoglobulin analysis is complicated, and a lot of times the lab sample isn't processed correctly. It has to be handled right, drawn right, like all this stuff. And half the time I feel like that I order cryoglobulins, it gets it gets rejected by the labs. So anyway, I think what, the open questions, as you were saying, is we need an ANA and an anti-smooth muscle antibody to further consider autoimmune hepatitis. And then we still don't know whether the globulins are polyclonal or monoclonal, and an SPEP and light chains are an important step as well, because plasma cell dyscrasia can have a lot of immunologic phenomena associated with it that could potentially be involving the liver, the blood vessels, skin, etc. And then absolutely, so if the rash reappears, I think it would be important to demonstrate that it is inflammatory, or maybe it will surprise us to see that it's not. And then if all else fails, there's a liver biopsy that is possible too, if we don't know with non-invasive testing. Valeria, why don't you bring us home, and we'll see what we can learn from you.
I have one more differential, sorry. I would say IgG hepatitis and IgG pancreatitis as well, IgG4. So we can also get the IgG4 levels, because the globulins are high. So we can see if those are elevated, and that can give us a clue as well to rule out.
Love it. Love it. You might have saved the day. Just kidding.
Yes, Anusha, that's exactly what we also thought. And yes, so to answer your question, we actually did a hemolytic anemia panel, and well, the MCV was 80, and haptoglobin was normal. There was no hyperbilirubinemia. As I said before, LDH was also normal. Sorry that I don't have the exact values, but we did rule out that possibility. The SPEP was negative, surprisingly, because we were also thinking about globulins, but Anna was also, I believe someone asked HIV testing, and it was done and it was negative. And Anna was done and it was positive, but all other autoimmune panel was negative, anti-Smith, anti-SM, with the whole, I don't remember exactly the name, but that includes all anti-muscle antibodies, and they were all negative. Also, only the Anna was positive. So a liver biopsy was done. And yes, exactly, Anne-Marie, that was what I meant. The Anna panel or INA panel was done and it was all negative. And liver biopsy was done and it showed a marked lymphocytic infiltrate, and it was determined as compatible with autoimmune hepatitis. But the patient actually, as she didn't have any clinical course that was kind of affecting her life in a great way, just as episodic clinical symptoms. And actually the biopsy wasn't really, the lymphocytic infiltrate wasn't like changing much the structure of the hepatobiliary or the liver. So she didn't actually receive any treatment, and she was only discharged with controls in the future. Because in autoimmune hepatitis, well, as you must know, in cases when there is an elevated IgG, which was not the case, or elevated transaminases, more than 10 times the normal values, usually corticosteroids are given or any other immunosuppressive treatment. But it is also possible if there is no really a lot of clinical symptoms and the biopsy is not showing us severity, and IgG and transaminases are not really very elevated, it is also possible to discharge a patient without any treatment for the moment.
Thank you, Valeria. What a great case, and yeah, just sort of story of the background symptoms and the abnormal labs, and really resulting in needing kind of tissue confirmation of the diagnosis.
Did the chat Google any greasy food wisdom that they can share with us?
Kernan says zero clue. Okay.
I bet if Travis was on the call, he would have found some like great article.
Chiara, do you want to take us home with a summary of some teaching points?
Hi, of course. Thank you, Valerie. Amazing case as always. So we had an abnormal lab approach with elevated transaminases, and Steph said us that this is an amazing approach because we have to ask many things. One, chronicity, and to assess chronicity sometimes is difficult because you don't know all the background from the patient. Also, we have to see if there are symptoms associated and the pattern of this abnormal lab. Is this, in this case, if this was hepatocellular or maybe there was FA associated, like in cases like cholestasis, or this was a mixed pattern. So then we had elevated an approach by Kiernan about elevated transaminases, and this we have to think about infection like hepatitis or some other virus, abscesses, metabolic causes, toxic or infiltrative diseases. Then we knew that this patient had petechiae, but these petechiae were like self-limiting and intermittent. So our approach for that was first to think about blood abnormalities, nutritional deficiencies, some vascular abnormalities, in this case vasculitis like leukocytoclastic vasculitis, ANCA, IgA, cryoglobulinemic vasculitis. After that, we have to think about liver diseases when we see petechiae like thrombocytopenia, and lastly, but not less important, infections. Finally, well, not finally, we also had non-blanca lesion, and Anusha told us that when she sees a non-blanca lesion, she thinks about autoimmune diseases, and what support that autoimmune disease, that there is presence of pain and myalgias. So this was a very important clue to think about an autoimmune disease. Also, we have to think about the association, but we don't have to always think that there is an association. We may have an association or a correlation that Sabin told us. This is a great pearl. So we have to think about why greasy food is making this patient have petechiae or lesions. We don't know yet that, but maybe there was a cholestatic disease. Not so sure about that because there wasn't any lab abnormality for cholestatic disease. Maybe malabsorption disease, allergic to any particular food. Then we had, after we had all the the basic metabolic panel and all the labs, we had that there was only as isolated elevated ALT and AST. So with that, we have to think about maybe this is some viral hepatitis or vascular or celiac disease or non-alcoholic fatty liver disease, formerly called NASH, or Whipple diseases or vascular. So then we got the gamma gap that was elevated, but after a SPEP was performed, this was normal. So we don't we didn't knew what to do with that. So Anusha told us how we can make progress. How we can make progress in this case, we have to ask about lipid levels, maybe think about a lesion biopsy or a liver biopsy, some to make a broader panel, like asking for ANA panel, IgG levels, and cryoglobulins. So you all were totally right. I love Anusha approach about asking for liver biopsy, because this is what finally gave us the final diagnosis, that is autoimmune hepatitis. So thank you so much, friends. Love today's case.
Thank you, Kiara. Great teaching and summary. Kirtan and Anusha, fantastic job. And Valeria, thanks for a case. We'll see you guys in a few weeks. Have a great time since then. Take care.
Thank you.